So first, I'd like to call Dr. Aaditya Joshi. He's a phaco trainer at Amida Eye Care, and he's a excellent surgeon and a good teacher also. We'll have him talk on the perfect scleral tunnel. So the scleral tunnel is something that is very, very specific to MSICS. Now, if you can get it right, you'll find that the astigmatism you create with SICS will go down and down, and also the waterproofing, water leaking, he'll explain in detail.
Thank you, Dr. Ashish Kurilla and organizing committee for the opportunity. I'll be speaking on constructing the perfect sclerocorneal tunnel. As Dr. Ashish Kurilla said, this is the most important foundational part of the SICS, because once we practice this sclerocorneal tunnel well, we can have a better surgical outcome. For a beginner, especially, the prerequisite for a good scleral tunnel is having a good block, either a local or a subtenon, a bridal suture, congenital peritomy, and then scleral incision and actual tunnel construction. As we can see over here, for a good exposure and stability of the globe, we should have a bridal suture. After that, with a colibri forceps and a congenital scissors, take first vertical cut into the conjunctiva, separate the conjunctiva and tenons, bare the sclera well, and then do a minimum but gentle cautery so that there is no charring. Because if we do over cauterization, it can cause wound leak, scleral necrosis, and will have more complications later on. Even more astigmatism can be caused. Then we move on to scleral tunnel construction. The main part, why we want this good scleral tunnel? Because it increases the oppositional surface, improves wound healing. It can reduce surgically induced astigmatism. It has a self-sealing effect because of the three-planar architecture, and it can be a sutureless surgery. So this is how a scleral tunnel should look. It has an external incision, tunnel in the sclera, in the cornea, and the internal incision. The main three steps: external scleral incision, sclerocorneal tunnel, and internal incision. For the external scleral incision, four main things we have to consider: the size, the shape, location, and depth. For the size, we have to assess the size of the incision to make according to the density of the nucleus. So if a harder cataract is expected, we have to have a little bit longer incision, maybe a 5.5 to 7.5 would do for most of the cases. For the shape, different options are available like smile, straight, frown, or even inverted bat wing. So smile is like parallel to the limbus, but it can cause more astigmatism. The stability may not be as good. Straight incision, better than that, it will be like a tangential to the limbus. And the most commonly used are frown or the inverted bat wing. The frown is like the reverse of the smile, and inverted bat wing is like a straight incision with two side back cuts, which will allow the larger nucleus to come out of the anterior chamber. Location wise, we can have a superior or temporal. Superior has a better tunnel stability as compared to temporal, but the temporal has the capacity to neutralize the pre-existing astigmatism. So that way temporal might be better, but still temporal has got more chances of fish mouthing and opening up. For a beginner, superior might be a better choice. For the depth of the incision, it should be almost half of the scleral thickness. It should be uniformly deep all along the length. Too shallow can cause buttonholing. Too deep can cause thin floor and premature entry and uveal tissue prolapse. So this is a small video of a bat wing and a frown incision. As you can see, we have to firmly grip the globe with a colibri forceps closer to the limbus and make the either with a incision with the crescent with bevel down, or a surgical knife 15 number blade, or even a guarded knife can be used by a beginner. It should be a very precise single stroke incision. Then we can go on to sclerocorneal tunnel construction. The main step is, after we make the first incision, turn the bevel up now. The footplate of the crescent should be along the scleral surface, and then as shown in the figure, we have to go towards the cornea, towards the limbus like 1, then you have to cut with a swirling movement to the 2, and then cut back outwards. That is the way to go ahead. Then how to judge the depth of the tunnel? whether we are in a correct plane. So if we can see the blade too clearly, that means we are too superficial. If it is not visible or barely visible, that means we are too deep. So we have to get a correct depth plane, and we should see the blade translucently through the roof of the sclerocorneal tunnel. So this is a small video which shows the same. I'm delineating the first incision created with the crescent blade, so I get into the correct plane, and I move forward with a swiveling movement towards the limbus around 1 to 1.25 millimeter into the cornea. And as you can see, I'm trying to follow the contour of the globe. And to make the side pockets, the crescent goes halfway into the cornea, halfway into the sclera towards the pocket. This pocket creating will be very important because the larger nucleus will get accommodated through this side pocket. And you can see the translucency of the blade through the roof of the tunnel. That means we are in a correct plane. Cut backwards only, never forward. Only for the side pockets we can do this swiveling movement with half of the blade into the cornea and half into the sclera. Next one is keratotomy, which is the third plane of the tunnel, where we have to make a dimple down technique use. The keratotomy is used, ensure that it is sharp and the anterior chamber is firm. Because if it is not firm, then we can have more complications. The tunnel entry won't be good. We can have a Descemet strippings. So we have to have a sharp instruments. And this will be a forward cutting movement this time. I'll show a simple video of this. As you can see, we are going in the same plane, which we have created by the crescent knife. Just dimple down and enter into the anterior chamber. Once we enter, keep the keratome parallel to the plane of the iris, so that we have a correct straight incision which is around limbus to limbus 9 to 10 millimeters. So an ideal tunnel will be around 1.5 to 2 millimeter posterior to the limbus, depth half of the scleral thickness, inner lip around 1 to 1.5 inside the limbus, self-sealing 3 planar and astigmatically neutral. It should have a good square geometry so that we have a good stable tunnel. So the key takeaway points would be a sclerocorneal tunnel is a foundational step for any SICS surgeon. Tunnel quality depends on the size, site, shape and configuration of the wound, because that is going to directly impact the strength and stability of our wound. Correct incision depth should be maintained. Follow the natural contour of the globe. While cutting out, we should always follow the natural contour, otherwise we can have buttonholing. Use sharp blades and use the proper dissection technique so that we can have uniform tunnel planes. Even after trying best, some of the tunnels still might leak at the end of the surgery, or we might have a premature entry where the wound won't be stable. We shouldn't hesitate to apply sutures in such cases, because that will give more strength to the incision and it will be a safe. And last but not the least, for a beginner especially, a regular wet lab practice will be of very much utmost importance, because getting these correct surgical planes, having the practice only will allow us to do a best surgery actually in the human eye. Thank you so much.
Thank you, Dr. Aaditya.